and welcome to the Clinical Liver Diseases video series. CLD is an official digital learning publication of the AASLD. I'm Gabriela Kuftinec, gastroenterology fellow at the University of Miami and one of the authors of Hepatic Manifestations of Whipple's disease. We've all heard of Whipple's disease, although probably few of us have actually seen it. It's a rare disease caused by infection with the bacterium Trichoderma whippleI. Typical symptoms are diarrhea, weight loss, and arthralgias, but the disease can really affect any organ system. Annual incidence is about 6 cases in 10 million people worldwide, usually middle-aged European white males with some exposure to soil, for example, farmers. Here, we review the hepatobiliary manifestations of this rare disease. So, we've established that Whipple's disease is very rare, and although we noted it can affect any organ, hepatic involvement is a rare manifestation of this rare disease, with only few case reports in the literature to date. The main hepatic manifestations that have been thus far reported include liver test derangements, hepatosplenomegaly, ascites, and jaundice. The disease typically has 2 stages. The first, characterized by arthralgias and arthritis, and the second, about 6 years later, by abdominal pain, diarrhea, fevers, and migratory joint pains. Liver biopsy histology might show non-caseating granulomas in the portal and periportal spaces with periodic acid shift positive granules. However, the staining is sensitive but not specific, as a similar pattern can be seen in alpha-1 antitrypsin deficiency. It's thus very important to specifically mention this possible diagnosis to your pathologist to clue them in on key features. Ascites is another uncommon manifestation in Whipple's disease, possibly from the malassimilative process caused by infection that leads to a protein-losing enteropathy. This would lead to a low SAG of less than 1.1 in the acidic fluid. However, the granulomatous nature of hepatic involvement in Whipple's disease can also theoretically lead to non-cirrhotic portal hypertension and would thus lead to a high SAG. Therefore, SAG might not be a helpful test in the diagnosis. Several case reports describe elevations in liver chemistries, however the exact pattern remains unclear. One described a fatal case of acute liver failure with aminotransferases over 1,000, an elevated alk phos, and direct hyperbilirubinemia, as well as a coagulopathy. Another described a cholestatic pattern with markedly elevated alk phos. Therefore, liver test derangement pattern is unclear. Given that antibiotics are the treatment for this disease, it is also possible that drug-induced liver injury can cause liver test derangement. Without this treatment, the disease is eventually fatal. It's important to keep the differential of liver enzyme elevation very broad, and in particular to consider Whipple's disease if relevant extrahepatic manifestations are also present. Table 1 shows treatment options. In conclusion, although Whipple's disease is exceedingly rare, in patients with cardinal symptoms of weight loss, abdominal pain, diarrhea, and arthralgias, should liver test abnormalities be present or there are signs of hepatic decompensation without a clear diagnosis, one must think of this rare disease. On behalf of the CLD team, I hope you found this review of the hepatic manifestations of Whipple's disease useful. For more information, please visit www.cldlearning.com. Thank you for watching.